So moving on to the pathology of the which you should know for the exam. So this is a picture of oral candidiasis. Okay, so, or it could be oral candidiasis, sometimes pharyngeal, oropharyngeal candidiasis. Sometimes you get esophageal candidiasis. So whenever you see an oropharyngeal candidiasis, usually the description is that you have a curdy white patch. Okay, so do remember for MRCP part one there are no images; it's only a description. So this is just for understanding. You will not be given any picture in MRCP Part 1 exam. You'll be given a description. So you need to remember the description only. So if you have a curdy white patch in the oral cavity, you should suspect oral candidiasis. Now, oral candidiasis is usually seen in patients who have got some risk factor. For example, patient who's a diabetes, who's uncontrolled diabetes, patients who are immunocompromised, especially they have HIV infection, or patients who are having steroid inhalers. So asthmatic patient who inhale steroids, what happens if the technique of inhalation is not appropriate? So most of the steroids will land up in the pharynx or in the oral cavity. So generally, they need to synchronize their inhalation with the steroid drug, but a few of them have some procedure failure or mechanical failure, which will result in deposition of the steroid drug in the oral cavity. So that acts as an immunomodulator, and the patient can develop oral or pharyngeal candidiasis. So that could be area of erythema. So you see a predominantly white curdy patch, and at the border usually there's a reddish hue, which is known as erythema. So this is the oral candidiasis, and the treatment for that is usually fluconazole. So we have to give fluconazole. Usually tablets can be given 10 mg, so 150 mg to 200 mg for about 10 to 14 days. The treatment holds the same for esophageal candidiasis. So patient with esophageal candidiasis usually present with some kind of dysphagia, and it is diagnosed on upper GI endoscopy. Next, about hairy leukoplakia. So this is the hairy leukoplakia. You see this hair-like projection, and it's on the lateral surface of the tongue. So description is all that you need to remember. So curdy white patch can come anywhere in the tongue, but anywhere in the tongue, whereas the hairy leukoplakia, generally the description is on the lateral surface of the tongue. Now, this is caused by Epstein-Barr virus, which is one of the viruses which belong to herpes group of viruses. That means it contains DNA. It has got a white patch on the side of the tongue with a hairy appearance. So these are the two oral conditions which you need to remember. Apart from this, you may get some oral ulcer, which is commonly seen which is the aphthous ulcer. It could be pemphigus vulgaris, which can also present with the oral cavity involvement. It could be lichen planus, other skin condition which can present with oral ulcer. So we're going to discuss about that in a lecture in dermatology. Moving on to the second symptom, that is the symptom which is related to the esophagus, which is called dysphagia. So these patients who come with dysphagia, we have a set of differential diagnoses for them. So this include esophageal cancer, esophageal malignancy. So in a scenario, when you consider esophageal cancer, usually it's an elderly patient who has come with some weight loss and fatigue, okay, and he's got a couple of risk factors for development of esophageal cancer, such as smoking, alcohol use, or what's called as gastroesophageal reflux disease with presence of Barrett's esophagus. We're going to discuss all these in subsequent slide. But when you have a patient who's coming with the dysphagia, there is a common scenario in MRCP part 1. You should consider cancer in a patient who's got elderly, who's got weight loss, who has got loss of appetite, who has got some risk factor for malignancies such as smoking or alcohol use. Esophagitis is an inflammation of the esophagus. It could be specific secondary to some drugs infection. It's usually short-lived. We can get drug-induced esophagitis, which is quite common in a drug known as bisphosphonate. So you might have heard of a drug bisphosphonate, which is given as a primary prevention of osteoporosis as well as the secondary prevention. That means it is used to prevent osteoporosis in high risk individuals. It's also a drug which is used and the treatment of osteoporosis. Okay, so the drug bisphosphonate, it needs to be taken on empty stomach in the morning, and the person has to stand erect and then consume the tablet with some liquid, and it has to, because it is quite corrosive and it can injure the esophageal mucosa, resulting in esophagitis. Candidiasis, we already discussed, it can cause dysphagia. The clue will be its underlying risk factors. We have achalasia. Achalasia is basically a neuromuscular disease where there is defective relaxation of the lower esophageal sphincter. Okay, normally when the food comes to the upper part of the GIT, upper esophageal sphincter, it will relax and the food will enter the esophagus. When the food comes to the lower part of the esophagus, it's temporarily collected there, and subsequently when the food uh, um, there's enough amount of food in the lower esophageal sphincter, it will slowly relax and the food enters the stomach. But in these individuals who have achalasia, the lower esophageal sphincter is quite tonically contracted. So there is no relaxation, resulting in accumulation of food in the throughout the length of the esophagus. Then you have the pharyngeal pouch. Pharyngeal pouch is basically a problem in the laryngopharynx here. What's happening here is the pharynx, lower end of the pharynx, has got two muscle, which are known as the thyropharyngeus and cricopharyngeus. You not remember the name of these muscles, but the area in between these two muscles is contains only mucosa. Okay, so whenever there's increased pressure inside the lumen of the pharynx, uh, there is an excessive pressure, lateral pressure exerted in these mucosa, and the mucosa just can bulge out of this muscle and can produce as an what's called as an pharyngeal pouch. So we're going to discuss that in the next slide. Systemic sclerosis. Systemic sclerosis is an immunological condition characterized by presence of sclerosis both in the subcutaneous tissue as well as internal organs. When you have limited scleroderma, that means it involves the extremities. We have a specific type of limited scleroderma, which is known as CREST syndrome, which stand for calcinosis cutis, Raynaud's phenomena, esophageal dysmotility, sclerodactyly, and telangiectasia. Okay, so do remember systemic sclerosis is one of the important topics in MRCP Part 1, Part 2, even in PACES exam. So you need to know about systemic sclerosis and how it presents. So somebody has come with symptoms of the fingers and who has come with the Raynaud's phenomena and has got dysphagia, you should always consider esophageal dysmotility. Myasthenia gravis is a neuromuscular junction disorder which has got an periodicity. That means symptoms will worsen with exertion. Usually, these patients present with the diplopia, double vision, because of the involvement of the extraocular muscles, or dysphagia because of the involvement of the pharyngeal muscle, or they can come with the proximal muscle weakness, usually upper limb or lower limb weakness. So these are the symptoms of myasthenia gravis. Globus hystericus is an psychological condition, more of a functional disorder, where the patient is quite anxious about swallowing, and that's the reason why the patient comes with dysphagia. So these are the set of differential diagnoses in the MRCP exam when you see a scenario with dysphagia. Okay, the order of preference, depending on the scenario, could be esophageal cancer, it could be achalasia cardia, it could be pharyngeal pouch. These are the common three differentials which you will find in an MRCP exam. So back to the lecture, we'll continue with the differential diagnosis of dysphagia. The first is the pharyngeal pouch. Here you can see the anatomy of the larynx. So this is the thyroid cartilage, which is one of the unpaired cartilages. Below that, we have the cricoid cartilage, and this is the cricothyroid membrane here. On the posterior aspect, you see two muscles. One is the thyropharyngeus. That means it starts from the thyroid inserted into the pharynx. That is for thyropharyngeus. You also see another muscle known as cricopharyngeus. That means it originates in the cricoid cartilage, gets inserted into the pharynx. And the area between these two, which is this part, is slightly, does not have any muscular covering. And this is known as Killian dehiscence. Now, this is the area or through which usually you have the pharyngeal pouch. So it's an pharyngeal pouch is an posterior-medial diverticulum. So I'll show a picture of the diverticulum, so that it's quite clear. Okay, so this is the diverticulum, also called Zenker's diverticulum. So from the posterior-medial surface of the pharynx. So it's a posterior-medial diverticulum or herniation through Killian dehiscence. Killian dehiscence is a triangular area in the wall of the pharynx between the thyropharyngeus and cricopharyngeus. This is commonly seen in elderly who have the less elastic tissues. Common features are dysphagia because the food gets stored in the pouch, so they have difficulty in swallowing. Regurgitation of food, that means whatever food is stored in the pharynx and the pouch can come up again. That is called regurgitation. Aspiration, because there could be microaspiration. The food from the pharynx can enter into the respiratory tract. There could be neck swelling, which gurgles on palpation. Okay. So when you, if the swelling is quite big, it will appear, if the pouch is quite big, it will appear as a swelling in the anterior or just lateral part of the neck. So when you press that swelling, you'll see a gurgling because it's a hollow swelling. Halitosis, that is the bad smell. Investigation of choice could be contrast swallow. So we take an oral contrast, ask them to swallow. You'll see the contrast getting into the pouch. An upper G endoscopy should be done with caution because when you insert an endoscope, it may pass through enter the pharyngeal pouch, and when you try to further maneuver through the pouch, you may cause rupture of the esophagus. So this is the cricopharyngeal muscle, and this is the Zenker's diverticulum. So you ask the patient to take an oral contrast, and the contrast will enter into the pouch rather than going into the esophagus. So few of the contrast may go into the esophagus, but few of them will remain in the pharyngeal pouch. That's how we can diagnose on the barium studies. Second important thing is when you do an upper GI endoscope, you want to enter into the esophagus. Esophagus is a collapsed structure, so there is a tendency to the scope to enter the pharyngeal pouch, and when try to further maneuver, it may cause rupture of the esophagus, rupture of the pharynx, the sac. So this is an lateral. This is a view, anterior-posterior view, where you can see the pharyngeal pouch. We can see a small. This is a plain study, so it may be slightly difficult to uh, appreciate, but here you can definitely, you can see a contrast study, you can clearly make out the pouch. Achilles